for a therapist, I think about, how do you view change? How do you view healing? How do you view like therapy even? What is that process? Because that will inform what modalities you go towards.
The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe, while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learn here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence. Hi, everyone. Lots of exciting things coming up. On July 20th, it's a Saturday at 10 a.m., Jennifer Hama and I are going to be talking to you about how naming your emotions can actually help alleviate suffering with chronic pain and illness. It sounds really simple, but it's really hard to do. So we're going to be doing a whole workshop on that. It's $17, but as usual, if you sign up for my email list, you will receive discount codes to be able to attend at a pay-what-you-can rate. The payments for these workshops go into hours spent working on them. And so if you are able to afford it, we ask that you do pay the full price. And if you're not able to afford it, then that is what the codes are there for. So please feel free to choose the option that truly works for you. And then on August 3rd, Rachel Hopkins and I will be doing a full day workshop. This will be from 9 a.m. to 4 p.m. with breaks and snacks. It's in person in Atlanta, Georgia. And that one is going to be helping you break out of the fear, pain, avoidance cycle that often happens with chronic pain and illness. There are things that happen physically and mentally in our body that cause a lot of fear, reasonably so, like physical symptoms or emotions that we don't want to feel. Like all of these things create obstacles for us to do the things we really want to do, like hang out with our friends and family or go back to work or things like that. So this workshop is all about getting past that pain, fear, avoidance cycle, learning the skills and tools it takes to navigate that, because it can be really hard and you deserve support in this. So that is what we're doing on August 3rd. That's a full day workshop. So that is $197 so long as you purchase it before July 27th. I believe that's the date. After that, price goes up to $250. So if you live in Atlanta or anywhere close by, then this workshop is for you, and I can't wait to see you there. Katie Casey is a licensed counselor in the state of Tennessee with over a decade of experience in the field. Her journey has taken her through diverse settings, from inpatient facilities to residential treatment centers, detox programs, and outpatient therapy. As the founder of Abundant Hope Therapy in Mount Juliet, Tennessee, Katie not only practices therapy, but also provides clinical supervision and facilitates continuing education trainings for fellow therapists. Katie specializes in working with individuals facing chronic pain and illness, navigating complex trauma histories, and supporting other helping professionals on their own healing journey. And if you're a therapist here and you like Katie's style, she'll be doing a CE workshop in August titled Pain, Illness, and Mental Health, a Holistic Approach. This seminar is for mental health professionals who want to improve their skills in working with individuals within the chronic pain and chronic illness population. Over the course of the seminar, there will be research presented along with case studies, practical examples on how to effectively assess, build treatment plans, and overall work with clients using a well-rounded approach. It'll be August 23rd, 2024 from 9 to 4:30 Central Time, and people can get 6 CEs through NBCC. The link for that will be in the show notes. Thank you so much for coming, Katie. I'm really looking forward to talking about treatment methods and modalities today, because I think that's a big question that comes up a lot. So today we'll talk about it from the perspective of, like, we're educating not only therapists, but also the general public. So it's like, what should you expect when you're working with a therapist? And there are different modalities to choose from, and different things work better for different people. So Yeah, I would love if you want to add anything about you and your practice and what you have been loving lately, and then we can get into maybe the modalities and in that conversation.
Yeah, totally. I think that this is a really important conversation, both for the provider, the therapist, and for clients, because then they can see what to look for in a provider as well. It's hard to really nail down, obviously, what is the right or wrong way because there isn't one. So it'll be talking about a lot of different things, I think, today, but I'm excited to do it because this is a very big passion of mine, both from the clinical perspective. I think this is an area that isn't focused on enough. But then also, as someone who has the lived experience of being, I deal with chronic health and conditions. And so I know it from my perspective. I have that lived experience. And so it's a passion for me for sure.
What brought you to diving into different modality types to like teach on it? Like, what was the passion there around it?
Yeah, I'm a big dork. I love learning. I'm very evidence-based. I always have been. I want to read the research. I want to know what works from that perspective. Early in my career, I thought I would get my PhD and I would teach and I would really dive in that way. And then I realized I didn't really want the academia side of things. And I'm really lucky to be able to facilitate trainings for continuing education. And so that's been really fun for me to be able to put together these trainings because I do get to dive into the research even more and really synthesize it for other providers.
Creating CEs kind of took that place of you didn't go for your PhD, but this kind of propels you to keep learning and putting the research together to then teach to other people.
Yeah, totally, totally. I didn't want to spend all the money getting my PhD, doing all of that. And I realized I don't really like doing the research. I just like reading about it. And then that teaching aspect is a big passion to help people feel more competent, to feel better around their skills as a clinician. Another big focus of mine outside of this population is working on burnout with helping professionals. And so I think education and simple practical tools is another big important part of my trainings and what I focus on. And so that comes out hopefully in my trainings as well.
What was the last training you did?
The last one I did was actually two trainings in one day. So I did the ethics of burnout and then trauma informed suicide prevention.
Oh, I like that. I don't think I've really seen trauma informed suicide prevention. That's interesting and good. I'm glad we're doing that. And what about, let's move into some of the chronic illness teachings that you do or love. Like, what has been really eye-opening for you or really helpful in diving into the research around like modality type and how to work with the chronically ill population?
Yeah, one of the biggest things that I've really discovered, especially in the last few years of just my own readings and my own CEs and trainings, is really looking at the importance of the nervous system within this chronic pain, chronic illness population. And because I do work so much with chronic trauma as well, that definitely overlaps. And so noticing more and more of the nervous system and the body and how important it is to acknowledge that within therapy and how we can do that within our scope of practice as counselors. Not obviously there's limits there. We are not doctors. We don't have that sort of training, but we can learn about it. We can help our clients with it and still do that healing therapeutic work with them. So it's been really fascinating to dive into that aspect more, learning from the somatic experiencing, just general stress and what it does within our body, window of tolerance framework, on and on, different ways of basically looking at the same thing but different ideas of how to conceptualize it. That has been a big focus of mine recently, just within readings as well as how I'm putting together some new trainings for the future too.
Yeah. What are you putting together?
One is going to be somatic based interventions for trauma. I will be working, or I am working with a friend and old colleague of mine who's a therapist as well, but also a trauma informed yoga instructor, where I will be doing more of the educational type pieces, and she will be leading more of the experiential and hands on and practice aspects that both as clinicians we need for ourselves because of secondary trauma, and then how to teach that for our clients as well. And as we do it and practice it ourselves, it's a lot easier to teach it and to help our clients with it. And these are things that are really helpful for those dealing with chronic pain and illness too, because what research shows and what I talk about in some of my trainings is that overlap between chronic trauma can lead to chronic pain and illness. It's not always that way. Obviously, there's genetic components or other factors that go into why those things develop for people. But looking at, again, the nervous system and how it plays a part in trauma reactions and some of those trauma symptoms and how it can impact our bodies, leading to chronic pain and chronic health issues.
Yes. Yeah. Yeah. That's, I think, such an important point because lately there's a lot of talk about, and we have the ACEs studies. We know that chronic adverse experiences as a child does lead to worse health outcomes as an adult. But like you said, it doesn't always mean it's the cause. It's usually the cause of an illness is there's several factors involved. And so just reiterating that for people to always remember when we're doing trauma work with chronic illness, it's not because your trauma caused your pain and now it's up to you to fix it. There's so many factors. Yeah. Do you want to speak to that at all?
Yeah, totally. I've had more people than I could count come into my office over the years. They've read Body Keeps a Score, or they've done something like that, which is a great book. I love it. And they're like, okay, I need to work on my trauma so I can get rid of fill in the blank, whatever it is. And there has to be an education piece there around what that looks like, that we don't know the mechanisms of what is going into their health issues, what is happening there. There could be a component, sure, that chronic stress in the body leading to possible inflammation, working on the trauma, working on their histories could help things not exacerbate in the future. But I am always very cautious, and I always talk with clients about the idea of complete symptom reduction, or even though I use the word healing all the time, talking about emotional healing, but physical healing when it comes to trauma work, because that can be a really dangerous place for clients to get into, and even providers to get into, to say, okay, if I do enough work, if I work hard enough, I won't feel this way anymore. And that's really rarely the case. You can feel better, but it's not often that way for people.
Yeah, yeah, and I think that working harder piece is a part of the trauma a lot of times for most of us. So it's maybe even learning how to work less hard and giving your nervous system a break. Yeah, it's hard. Else around interventions, and we could either talk about specific interventions or like modalities as a whole. Like you mentioned evidence-based, so I'm curious, do you lean into CBT, or it sounds like you also have a somatic bent. What is the research saying about somatic work? Because I think people are I'm a somatic therapist, but I think the research seems hit or miss with people right now, and I'm curious what you're finding.
Yeah, I think when it comes to, I guess, treatment, for lack of better words, or therapy with those with chronic pain and health issues, and that's the reason why they're coming to therapy, not another reason, and they happen to have these things. It's a very integrative approach is what's needed. And That is obviously a little bit of my framework and my experience. I know colors all of what I'm going to say today. It's how I view healing, it's how I view mental health. And so other people are going to have different opinions than me, and that's okay. But that's why I do focus a lot on what research shows to make sure it's not too skewed just based off of what I think and feel. Obviously, there is a somatic component there when it does come to pain and illness and how that shows up in the body. That could just be due to the stress reaction in the body and what that is doing to a person emotionally. I love the book Burnout. And in that first chapter, it talks about closing the stress cycle. And I think that's a great thing of just like anxiety and working with burnout with other clinicians, but even that idea of, okay, we have this stressor, we have this thing, we have to help our body relax. We have to help cue our body into, hey, you don't need to be in fight or flight anymore. You can calm down, you're safe now. But for people with chronic pain or chronic illness, if they're having stomach cramps or something like that, chronic pain is a stressor that never goes away. That your body is interpreting that as a reason to go into fight or flight. And that is a really difficult symptom to work with if you look at it just from that perspective. And so you have to look at it from multiple perspectives and figure out what is best for the client depending on where they are with their symptoms, what their mood symptoms also are, what their support system is like, what their needs are like outside of therapy as well. So again, I look at research and pull in a lot of different pieces. I do acknowledge the fact that in my training in school ages ago, a lot of my professors were very much a CBT approach to therapy. And so that is part of, I think, the foundation of how I view things. And I think a lot of probably people that went to school around my, again, about a decade or so ago, have a lot of that in their foundations. And I do think CBT does get a bad rap. There's a time and place for it, but it should not be the only intervention and it should not be the only thing done, because it can be really easy to, in essence, gaslight clients and minimize and not validate what they're going through if you just look from that approach. And so I was really lucky while I was in grad school to get trained in EMDR. And so I've been using that again for about over a decade now in different ways. And that is one of my main somatic approaches because it does include the body. It does include what's happening there. I've done some extra training specifically about somatic-based approaches with EMDR. There are other great somatic approaches as well. Research shows things like brain spotting, somatic experiencing, different things like that have good outcomes when it comes to this population. And so while I'm trained in EMDR, I'm not a end all be all. EMDR is the best thing ever. I like it. That's why I continue to do it. But again, there are other great somatic based things out there along the same lines. It's something I typically refer out to because I'm not trained in it, but I think about neurofeedback and biofeedback as well. There is, again, a lot of great research. I just think specifically around biofeedback, around things like tension headaches and IBS or just like GI issues, muscle pain and different things like that have all shown really positive outcomes with things like biofeedback and along the same lines with neurofeedback. So if for people that aren't familiar with those things, biofeedback is more of focusing on gaining control of certain physiological processes in the body. So things like heart rate, blood pressure, just becoming more aware of things like that. And again, it's been shown to be effective for a lot of things that people with chronic pain and chronic health issues could benefit from. Again, pain, stress, muscle tension, reduction, that sort of thing. And neurofeedback is similar but different. Obviously, that focuses more on having the feedback around brain waves, but still looking at pain management. Especially, I refer more to neurofeedback for my clients that have chronic headaches or migraines, or in a lot of brain fog that doesn't seem to be helped by other modalities with their providers, their medical providers. So that's where I think neurofeedback and biofeedback can also be helpful. Something maybe down the road I'll get trained in one of those because I think it's really fascinating.
Yeah, I think it's just bringing us back to, so it's important, I think, to have a foundation that you practice on, whether that is EMDR, somatic experiencing, even CBT, but then bringing in other pieces, like to be eclectic, to have, but also to know that you do have a main foundation. Otherwise, it can feel like as a therapist, you're floundering. You don't know where to pull from what. So it's good to have a foundation, but then also be open and aware of all these other aspects. I think even within somatic experiencing, which is my training, there's acceptance and commitment therapy, and then somatic experiencing, which I'm so thankful for as my first kind of modality. But it's just remembering. So within somatic experiencing, I think they do touch on thoughts and meaning, but it's almost like it gets very much in the background. Whereas if CBT, your thoughts are right up at the front, and I think both could use some balance from each other, with each other, because your thoughts do matter and they do impact your body. Your body also impacts your thoughts. And so it's just learning how to use all of these different modalities, meeting a client where they're at. Someone might be really strong in their ability to think through things and really poor in their ability to feel through things. And we might want to, but then it could also be vice versa. And doing somatic work with someone who maybe already has that down pat, they might actually need some more cognitive mentoring. So
Right.
it can get confusing, but it's not when you look at the whole picture, it's not confusing. It all makes sense. But in the moment, as a therapist and as a client too, it can feel really confusing.
Yeah, and that's why I always recommend for clients that are moving or spouses or that sort of thing, looking for a different provider when they look online or Psychology Today, that sort of thing. It's finding someone that has a few set of interventions or modalities that they say they're trained in. I get a little cautious or a little wary if somebody says they're trained in too many things because, like you said, it can get confusing. It doesn't feel as stable of a foundation to work with as a client when you don't know what they're pulling from. Now, again, it does need to be integrated. I am trained in EMDR. That's a big foundation. I have the CBT background, and then I work with DBT skills often. I don't do the full DBT approach. That's just not really my style. But I do pull DBT skills often. And then I like a lot of mindfulness work as well. So mindfulness-based stress reduction or mindfulness-based cognitive therapy, I think, are other modalities that have been shown to be really helpful with clients. And again, just as a person and as a clinician, I gravitate towards and I use it with my clients a lot.
Two questions. How would you encourage a therapist to find what modality works for them? And also, how would you encourage a client to?
Yeah, that's a really good question. For a therapist, I think about how do you view change? How do you view healing? How do you view therapy even? What is that process? What does that look like? Because that will inform what modalities you go towards. For example, what I think about one of my supervisees I'm working with right now, because I do clinical supervision for those that are pre-licensed. We're exploring different things. We're going through different modalities. And for her, she is gravitating a lot more towards AC, so that acceptance and commitment therapy versus DBT. And a big reason for that is she does not like the full DBT model. Similarly to me, it doesn't fit my personality. But I did not have the opportunity to really learn about ACT early on. And so the DBT still stuck with me. She likes ACT and how she talked about it because it integrated a lot of things. It talked about seeing a whole person, seeing the different aspects of what's going on. I remember her saying it's about seeing the client's humanity. And that really clicked for her. And I thought it was a beautiful thing when we were talking about it, that she found something that sort of explained what was already going on in her head of how she viewed therapy and how she viewed healing and working with clients. So I think that's a big aspect as a provider, of finding something that already fits and is already structured for how you view therapy and that therapeutic relationship. I think another aspect is looking at outcomes. What sort of outcomes do you want for your clients, or what outcomes are typically wanted by your clients? If you see clients with depression often, I want to feel happy. Okay. What modalities work on that sort of outcome? What modalities have the outcomes that you're wanting? And trying to find that. One of the reasons I love doing clinical supervision is helping people explore what fits for them, because it's not going to be the same things that I use, because I view people differently. My brain is different than other people's, right? And so there's going to be exploration there. I was much more rigid in my early career of, this is what I do and this is how I am. I think most clients are early on. And I've become a lot more fluid, I think, in moving in between the modalities that I am trained in, because I've become more comfortable with it. So I think that is another aspect when it comes to clinicians, is trying different things and finding what works for you and being open to other things in the future as well.
I really like the concept of thinking about what outcomes you want for clients, because I think a lot of us, especially when we're newer, it's whatever the client wants, which is true. Like, we want, like, you as a client have a say, but it can't, our role as a therapist is to lead. It's to lead, not to be authoritarian and tell them this is exactly what we need you to do. And I think some modalities are like that, which is, I'm also turned away from those, because it's too, okay, if you're not doing this thing in the modality, then you're a resistant client, and it's because you just don't want to work. You don't want to work. And it's, no, maybe this is just a really bad fit, and what you're telling me to do just isn't, like, conducive to what I'm trying to accomplish. So yeah, I do believe in client led, but they're coming to us for direction. And so you have to know, what do you enjoy as a therapist helping clients reach? What milestones do you help them reach? Which I think is what you're saying.
Yeah.
Obviously, acceptance and commitment therapy it's in the name, it's acceptance, but it's not to just tolerate what's happening to you. It's about not fighting so hard about what's there. And in removing that fight, you can actually accomplish more of the goals that are important and meaningful to you. You as a person, that's where the client-led piece comes in. So yeah, I really like that as a therapist, thinking about, what do you like to help clients achieve? And then someone might come to you not wanting to achieve that. They're just not a good fit client. You're not a good fit for them, and they're not a good fit for you. And that's where referrals come in, because we're all different. There's no one size fits all.
I always say in my first sessions with people, I might not be the right therapist for you, and that's okay. Let me help you find someone if that's the case. And that's an important part of it. I think another thing that just popped in my head with this too is thinking about the type of clients that you want to work with. If it is clients with chronic pain, chronic illness, then it is diving into the research and what does the research say. If you want to work with couples, then it'll probably be like Gottman method or doing something like that. Or if you want to work with a very specific niche, it's seeing what the research says and going with that, knowing that there's not one approach or one thing when it comes to the research, but it's diving in that way too, if you know what sort of population that you do want to work with.
Yeah, I wonder sometimes if I fell into ACT because it was already, I didn't know the research that it showed that it was incredibly helpful for chronic pain. And there was a lot of acceptance and commitment therapy research done on chronic pain. But I do wonder if I fell into it because it resonated so much for me as a person. And the reason for that, it works and it's good for this population. What other modalities do you find in the research around chronic pain?
Yeah, there are a few others. Is obviously good research around CBT. I also discovered when I was putting together a presentation last year that there is specific CBT for chronic pain training, which I wasn't aware of. The VA created it, of all people. So for clinicians, if they do gravitate more towards that CBT approach, or I think if you work with people in short term situations, that could be a really beneficial intervention. CBT is great in shorter spurts, right? Community mental health or different things like that. And so the VA could be a good resource looking at therapy. Clinical hypnotherapy has not a lot of research specifically around chronic pain, but I think about the stress component where it does show benefit, so it's almost adjunct. With lower stress, then the pain is typically lower, symptomology is typically lower, and health issues. So I think that's another component that's there as well. And then just overall, I think about this idea of just being really integrative. And that is what research is showing as well, is how can you incorporate these different approaches in based off of what the client needs. And I think that's where good case conceptualization, good assessment, an accurate assessment of what is happening for a client comes in as well, to figure out how to take these different approaches and apply them as best as you can.
Yeah. What can we maybe move into some assessment conversation? Yeah. What are some of the assessments that you use? And maybe a little bit of the logistics, right? But then also like here's how this helps me get to know a client better.
Yeah. So again, it's multidisciplinary. When you think about assessment and treatment planning and that sort of thing, it's not just what you're doing with the client. It is, again, referrals out to maybe things like biofeedback or neurofeedback, or even helping them advocate for things like physical therapy or other more integrative modalities that's happening there. Maybe it's talking with one of their medical providers and helping them advocate too. So I cannot stress enough how important having that multidisciplinary approach is. And so looking at assessments with clients and treatment planning with clients, you have to think about what can impact that assessment as well on the front end. If a client's filled out maybe some intake paperwork before you see them, or you have a blurb on them and you know there's some chronic pain or health issues there, then it's saying, okay, what's their fatigue level or brain fog level, or how are they with word finding because of their brain fog, or verbalizing what's happening, what's their pain in that moment, are they nauseous, or are they in a flare, or these things that can impact assessment. Just even thinking about that on the front end is so important. I took a really great training last year from Mark Grant. He's an EMDR therapist, and so it was specifically EMDR for chronic pain. But I think about some of the questions, even just when did the pain start? When did the illness start? Like really asking a lot of questions about their symptoms, not just, oh, okay, they have chronic pain, period, and moving on, but really getting into their symptomology around that as well. There is a couple different fatigue scales that are out there if a client is dealing with chronic pain, or if they're chronic fatigue syndrome, that you can find. There's the fatigue severity scale that's really simple, just to get a good picture of what that looks like for the client. I also sometimes use just even the spoon theory with the clients of saying, okay, How many spoons do you have today? What is that looking like? How do you typically use your spoons? And knowing a little bit more about what it takes for them to even move through their day and how that can impact possibly their mood. Obviously, pain and assessment around that is important because that impacts mood, that impacts their cognition levels, that impacts how they're living their lives. I don't really like that 0 to 10 pain scale. I think anyone who lives with chronic pain knows that is not great. I would encourage people to look up the chronic pain scale if they've never seen that before. It is, if I remember right, it's a 0 to 15 scale, and it just looks a lot different. And when you compare it to the 0 to 10 scale, because it's saying, okay, somebody who deals with chronic pain, they're 5, that might be their normal for them. They might never be out of pain. And they're good at hiding it. They're good at masking it. But if you actually see somebody in pain, you see somebody wince, you see somebody cry even because of their pain when they deal with pain every day, then that's like you've turned it up to 14 sort of idea, that it's unbearable when it's gotten that far. So it's important to remember that it's not just 0 to 10, that my 10 is way different than my client's 10, even if we both deal with chronic pain. And so it's getting more words around it, asking more questions of even where do you feel it in your body? If it's 6 in your neck, but if your knee's also hurting at a 4, but your back's hurting at a 2, it's thinking about the different ways pain can show up as well. I usually ask about how much does it impact, as it can be a high pain, but they can mask it or they can ignore it. So that's another piece. But yeah, I think outside of the pain symptomology, when we move into, assessing for depression or anxiety, I typically use the PHQ-9 for the depression assessment. That's something I give to all of my clients. And that I think is a great sort of screening for anyone. But there's a question on there about pain and how it feels in their body. And that is important to think about when you think about just even the differential when it comes to depression, because in the DSM, for people who do have to diagnose because of insurance or other reasons, in the DSM, it says these symptoms are not attributed to substance use or another medical condition. Now, I always say it's very easy to go from this is a flare to this is a depressive episode. And it can be both. The question of no interest or pleasure in doing things. If people say that's higher, I always say, do you want to do things, but your body just can't?
Right.
Do you really want to get up, but you just don't have the energy? You don't want to spend your spoons on doing that thing, so you have no interest in it. So it's digging into those questions a little bit more. Again, there will be a theme here of just asking more questions than you typically would, because so often, especially with things like depression and anxiety, they can be misdiagnosed or overdiagnosed for people that have chronic pain and health issues. And it's important to acknowledge the possibility of what the pain can do or health issues can do, and it not necessarily be mood first. I think about if you use the Beck depression inventory scale, if you use that, the last questions on there are about physical aspects, physical changes around depression. And I think it's like the last 7. And if a person answers the highest out of just those questions, my appetite is not there, or I'm very tired, I'm having issues sleeping, like those sort of questions, they would automatically score moderate depression, even if they scored 0 on every other mood related question. So it's looking a little bit deeper to what is happening with your clients, with how is your mood in a flare versus out of a flare. Again, do you want to be doing things but your body can't? Is it your pain that keeps you awake at night and that's why you're tired, or that's why you wake up? Do you typically need more sleep than most people? When you have spoons, how is your mood? When your needs are met, how is your mood? Like those sort of questions. And that's just even with depression, let alone other assessments that happen.
Yeah. I think it's really hard when I read like not due to another medical condition because I think they overlap so much, but you explained it in a way that I think was really helpful. It's, yeah, really just do you want? If we're talking about depression, like there's no desire to get out of bed, like then that's the depressive mind state, which might be caused by the physical issues that's going on, but there's a difference between being in that state versus, no, I really want to go to this thing tonight, but I just can't, like physically, like I can't do it. And there's just, yeah, such a difference there.
Yes, such a difference. And so it's just digging into these things more. It's asking more questions. It's doing things that hopefully clinicians are doing anyways, of being curious about things, not just taking things on face value and running with it and having assumptions with clients. But it's being able to dig a little bit deeper, notice the nuance that is there.
Yeah, yeah, absolutely. And so for clients listening to this, I think just recognizing that when we're asking you questions that we're asking, it should be from a place, you should sense the curiosity in your therapist. Like you should sense that it's not asking questions so that I can just fix you, because I think that's what we're used to with doctors. What is happening here and what's happening there? Okay, here's the medication for that. And there was no exploration, and that's probably why a lot of medications are trial and error already, and then on top of it, it might be doctor error because he didn't quite understand because he didn't ask enough questions. It's both. Medication is just, yeah, not foolproof either. But so yeah, I think you should just sense the curiosity with your therapist, which might be hard for you as a client sometimes too, if you're like, I don't want curiosity, I want answers, I want it to be fixed. And
I would encourage clients, if you're not sure why they are asking certain questions, if you want to know what their thoughts are of a treatment plan, what do they think about how they're going to reach your goals, what might these things look like, ask those questions. Ask, why are they asking you even more questions when you've already filled out the intake forms with some questionnaires in there? Ask those things if the clinician is not already doing that. I always do. I talk about that if I have to do a dissociation assessment, or if I have to do things that aren't part of my typical intake. I talk about why I'm asking these questions, and I talk about the purpose and what we can learn from it, and even what I see once I'm done. What do the results mean, in essence? And that's a really important thing. I mentioned trauma-informed care at the beginning, but having that collaborative approach, really talking with clients about what I'm thinking as a provider and where I think we're going, or even if it's broad brushstrokes, is so important. And so I would definitely encourage clients that if your provider is not doing that, ask those questions. Ask, hey, what is this for? How do you plan on using this? That sort of thing.
yeah, absolutely. For therapists who maybe didn't get a lot of training in assessment and even like specific interventions, and where would you encourage them to go?
I would look at trainings. It's something that if you're not learning at your site, especially newer therapists, if you're not learning wherever you're practicing, from supervisors, from other clinicians around you, then I would try to find trainings. A lot of assessments, especially assessments that are really well standardized, they are out there, they have been there for a while. There's a lot of free trainings or free manuals online that you can access. I, in all honesty, was very lucky in some of my positions. That assessment, it was hard at the time. I can look back and see how lucky I was to learn it then, because I'm a believer that having an accurate assessment, even an accurate diagnosis, really dictates treatment. Even for people I don't need a diagnosis for insurance or that sort of thing, when we know what's happening, we know how to format therapy and we know what sort of path to go down. So if you're not getting it at your site, I would look around online for trainings. Again, a lot are free and or very low cost. And maybe you can get some of your continuing education credits at the same time.
Yeah. It makes me think, yeah, some of us are a lot luckier than others in where we were trained and how we were trained, but then someone like you goes out into private practice and now you're providing those trainings for people. So it's okay. I think it's okay if someone didn't get, we're all just paying it forward and teaching and doing what we can to make sure that eventually we all become well-rounded. If we stay in this field long enough and you're willing to keep learning, you'll get what you need. Yeah.
That it's a big reason why I do the supervision and the training aspects is I know I'm lucky with I had good clinical supervisors. I had good training, and I want to be able to give that to people as well, because I know not everyone had that experience. And I also know not every training is good. I've been to many where I think I might have known more than the person teaching, or I was trying not to fall asleep the whole time, those sort of things. And so I want to engage people and engage the community that I'm in, that sort of way.
Absolutely. The trainings that you do, do they tend to be local to Tennessee, or?
I do both. I do both virtual and in person, and I'm in the process of doing what's called at home, so self-paced sort of things. That is hopefully going to be live by the end of the summer. So right now they're virtual and in person in the Tennessee area, but I'm open to traveling. It's just where I've had them so far.
Yeah. Yeah. And then as far as like CE credits, are you nationally like certified with NBCC or?
Yeah, so I'm certified with NBCC because I am an LPC. It made the most sense because that's where I typically get my CEs through. So right now it's just NBCC.
Okay, cool. And do you have all this on your website? Can I link to?
Yeah, so my website is abundanthopetherapy.com, and at the top you will see CE trainings, and you'll see all of them that are live, so all of them that you can go ahead and register for, and then a list of ones that I've previously done or ones that are upcoming. I just don't quite have all the details together yet.
Awesome. Good. Is there anything else you want to leave our audience with today before we head off?
I think the biggest thing is, speaking just directly towards clients or people looking for therapists, is I would look for people who have that integrative approach to their treatment. I would ask a lot of questions. Be that squeaky wheel, just like you probably have to do in doctor's offices and that sort of thing. Don't feel like you have to endure a therapist that you do not think is a good fit for you. Give it a session or two, unless there are massive red flags in the first session. But give it a session or two to try it. But advocate, ask questions, do what you need to get what you need out of therapy, because it's ultimately your time and your money, and you should get what you need out of it.
Yeah. Awesome. I agree with all of that. Thank you so much, Katie.
Yeah.
It was a pleasure. Thanks for listening. If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need. And lastly, leaving a review really helps others find this podcast, so please do if you found this episode helpful. And P.S., clicking subscribe ensures you'll be here for the next episode. See you then!